Welcome to our podcast series, New Era in Obesity Drug Development. Today, our speakers will discuss body composition and muscle mass. What matters more, quantity, quality, or both? Our speakers are Claudia Filozof and Arya Sharma. Dr. Sharma has authored and co-authored more than 250 articles on the management of obesity and related cardiometabolic disorders, and he has lectured on the subject all over the world. Claudia, let's get started.
Not so long ago, only bariatric surgery could lead to a two-digit percentage weight loss. GLP-1 agonists and incretins have definitely changed the management of obesity and type 2 diabetes and related cardiometabolic disorders. However, that data suggests that there is like a 30-40% loss in fat-free mass, and the implications are still uncertain. Body composition is becoming a concept of increasing interest, and it has been incorporated in clinical guidelines, but also in regulatory guidelines. Preservation of muscle mass is specifically important in older patients and in those ones at risk of sarcopenia. Preservation of muscle mass is not only important due to the potential association with frailty, but also for long-term weight maintenance. Dr. Sharma, the real impact in muscle loss is still uncertain, and the implications in muscle health and long-term weight maintenance, a topic to be clarified in the next few years. What's your opinion about this aspect, and what do you recommend sponsors to do to get better clarity about the impact in the different body compositions of the new incretins?
Well, when we look at body composition, we're talking about something that's actually quite complex, because when we talk about body composition, yes, we do have fat mass, and then we have lean body mass. Now, lean body mass is not just muscle. Lean body mass is all the tissue that is not fat. And of course, there's a lot of fluid in this tissue. There are lots of organs in this tissue. So when we talk about lean body mass, we use various formulas to try to calculate how much of that lean body mass is actually skeletal muscle. Algorithms are algorithms, and it's never a precise calculation. What makes it perhaps even more complicated is the fact that lean body mass, not only does it not represent muscle mass, it also does not represent muscle quality. So for example, if you look at a marathon runner, these are very slim people. They don't have a lot of muscle. They're very athletic, and they can run 40 kilometers, right? So they have great muscle, but they don't have a lot of muscle. In contrast, when I look at any of my patients who come into my clinic with BMIs of 35, 40, 50, they actually generally have a lot of muscle. Now, maybe that's not great quality muscle, but they certainly have a lot of muscle because they need the muscle. They need the muscle to carry the weight, because if you're trying to carry 100 kilos around with you, you're going to need a lot of muscle. So what happens when people start losing weight? Of course, they lose some of that muscle because you don't need the muscle. The body does not keep stuff that it does not need. So one of the things that happens when people lose weight is, yes, they lose the fat mass, but they also lose the muscle that they need to carry the fat, which is no longer there. So what we also know is that as people reduce their muscle mass, especially if this is combined with physical activity, we know that the quality of the muscle actually gets better. You can actually do the same amount of work with much less muscle. What counts for the patient and probably, counts for quality of life and perhaps counts for survival is not the amount of muscle that you have, but it's the quality of the muscle you have. Now, having said that, of course, there may be some vulnerable populations. There might be the elderly, there might be the frail, there might be the people who are starting out with sarcopenic obesity, where if they lose too much muscle, maybe there could be possibly an impairment in activity. But yes, there are certain populations we need to look at. Obviously, we have to do what we can to try to sustain muscle mass, and we have lots of studies showing that if you do resistance training, if you maintain your protein intake, then maybe you can decrease the amount of lean body loss. At the end of the day, the only thing that really counts is not the amount of muscle, it's the quality of the muscle.
Very interesting concept, and also the discrimination between the different terms like fat-free mass, lean body mass, or muscle mass, right? I would like to ask your opinion. What assessment, because obviously DEXA or even MRI, they give an idea about quantity and not quality. So what do you recommend the sponsors to add?
There are a lot of validated functional measurements tools. You can start with the most simple one, which is a simple hand grip exercise. It's very easy to do. It costs you almost nothing. And if that is not decreasing, I would not be concerned about the muscle. And in fact, what you'll see very often is that actually increases as people lose weight, because one of the things we know about muscle is when people lose weight, the muscle they have becomes more efficient, especially if they're also using the muscle, if they're also active. There's a whole bunch of these tests. There's the stand up and walk test. You can time people's going, which is not just a measure of function, it's also a measure of fitness. And we know that these measures actually correlate very well with important things like outcomes, like survival, like presence of other comorbidities. So really, at the end of the day, I want to see functional tests. What I really want to know is, are you losing the ability to do the things that you need to be doing?
In terms of long-term weight maintenance, we do know that fat-free mass is an important component in basal metabolic rate. So what about the impact of muscle mass in long-term weight maintenance?
The organs that burn calories are your brain, your kidney, your digestive system, your immune system. Almost every other tissue in the body burns more calories than resting muscle. It is the only component of resting metabolic rate that can really change, because I cannot change the amount of energy that my brain uses or the number of calories that my kidney burns or my digestive system burns. That kind of stays the same. The importance of muscle is not because it is the main source of burning calories or a major determinant of resting metabolic rate. The only reason we talk about muscle, as burning calories is because it's the only tissue where I can change the amount of tissue or I can change the amount of activity. The more fit I get and the more I use the muscle, the more efficient my muscle becomes. So if I have poorly trained muscle mass, it is probably using a lot more calories than if I have highly trained muscle mass, because what does training do? Training increases the fuel efficiency of muscle mass. That makes it complicated. So it's not the amount of muscle that is burning calories. That depends very much on how efficient the muscle actually is. That is resting. Now that difference gets even worse when I start looking at active muscle, right? Because the more efficient my muscle is, the more trained I am, I can walk the same distance or I can do the same amount of work by burning fewer calories. And that's one of the dilemmas that a lot of patients have. They start exercising, they lose weight, but then they have to do more and more exercise to burn the same number of calories, not only because they have lost weight, but also because they have become so much more fuel efficient, which means now they can do the same amount of exercise by burning fewer calories. And for patients, that can be very frustrating. All of your organs, except maybe your adipose tissue or your brain, trying to use fewer calories than before. And so that's a whole body concept. The body is trying to save calories because there's not enough calories coming in. That is adaptive thermogenesis. Now, part of that could be muscle and part of that could be muscle loss, but we don't know, how much of that is actually muscle mass. Now, can you preserve that? Can I increase that? I think the solution to adaptive thermogenesis, if you want to stop the decrease in muscle mass that is happening, is that you would probably want to harness other mechanisms, including things like, uncoupling protein, trying to increase the amount of brown adipose tissue, maybe get your adipose tissue to burn more calories.
Okay, very, very interesting concept. Dr. Sharma, any final concept, anything else that you want to share with us about the future of obesity drug development?
Well, I think at the end of the day, we have to come back to the point of saying, why are we treating obesity? We're treating obesity to improve quality of life, to reduce risk for comorbidities, to reduce hard endpoints. And those are the things that actually count. And so very recently, we put together a set of core measures. This is on ICHOM Obesity. If you Google that, you will find this is the International Consortium for Outcomes and Health Measures. And there we've actually set up a group of parameters that patients tell us are important, that we know are important to really determine whether or not patients are getting healthier when they lose weight. And those are the measures that actually count. Those are the measures that we should be focusing on.
Thank you, Dr. Sharma, for sharing your expertise with us. Exciting times in obesity research.
We are at the dawn of new generation obesity drugs, and at Fortrea, we are trying to understand the science of obesity in patients and drive better outcomes for our sponsors. Through innovation and research, we're unlocking deeper insights for more effective obesity treatments. At Fortrea, we unite science, clinical delivery expertise, and the patient perspective to make clinical trials efficient and patient-centric, driving better outcomes for our sponsors and bringing life-changing treatments to patients faster.